I'll also put the CME claiming information into the chat, and then I send it to Lisa and Sharon afterwards so that they have it. All right, Dr. Stanos, I'll let you take the screen back over.
Oh, okay.
Yep.
Is that okay, Sarah?
Looks great.
Okay.
We'll give it just a couple minutes before we get going, give people a chance to get settled.
Well, good morning, folks. Let's give it another couple minutes and then we'll get going with Dr. Stanos. Thank you again, Sarah, for all your coordination and guidance and scheduling, and I know it's a lot of work on that end to try to get these stellar colleagues and providers to join us on these mornings. So.
Before we get going, I'll remind everyone to please mute. Also, if you'd like to claim credit, the CME code and link is in the chat. Also, if you could please enter your first and last name and credentials into the chat, I will submit that to Swedish CME. Also, if you have any questions, please feel free to email me. My email is really easy. It's sarah.ambrose@swedish.org, and I'll stick that in the chat as well.
Well, welcome again, Dr. Stanos, joining us pretty much once a year the last few years about this ongoing path of pain management and opioid prescribing guidelines, rule changes, documentation, logic to a lot of this. Some patients that aren't particularly enamored with the whole deal, but to keep our arms around it, I think is pretty important, and we really appreciate your update this morning. Next month, Dr. Peter Nora will join us. Dr. Nora has been in the region for maybe not as long as I've been, but pretty close. And he's an esteemed neurosurgeon that will be with us next month. And then the following month, which would be, I guess, April, we'll have an excellent talk on sort of an update on COVID and COVID therapy, and actually one of the Swedish physicians that's actually published a sentinel paper here several months ago on post-COVID syndrome. So anyway, thanks again, Dr. Stanos. Sorry I've got to leave a little early, a bit later, but welcome again.
Thanks, Mark. And thanks, Sarah, for putting this together. So I'm Stephen Stanos. I'm a physiatrist and pain management specialist. I'm the executive director for rehabilitation and performance medicine. And so it's Swedish. That's the group that includes sports medicine, physiatry, pain management, and bone health. And I'm also the medical director of Swedish Pain Services. I do want to kind of quickly announce, I don't know if you saw, we're excited here. Part of our overview in clinical care includes sports medicine. And Providence Swedish announced that we're the official medical providers for the Sounders. So we added that to our portfolio. We also cover the Seattle Storm and Seattle University. So just a heads up for you guys. Hopefully you'll be hearing more about this relationship. And you probably noticed that Providence as a system is the official sponsor for the jersey. So it's been a busy couple of months here with us getting ready, taking care of the Sounders. But obviously today I'm going to talk about best practices for opioid prescribing. And I'm really glad Mark asked me to present because this is some good timing to circle back. There's been some significant changes, especially after COVID. And so I thought the timing's actually really good to give you an update of what's happening. So this is our group. James Babington is one of our pain management physiatrists up in Edmonds. Wilson Chang, who hopefully is going to join us here at the end, is my colleague, mostly works with me at First Hill and at Issaquah. Chris Merrifield has been in the region for a long time. Chris is downtown with us at First Hill, and he also helps with our inpatient consult service. We also have Fong Sing, who's in Edmonds and in First Hill, who's anesthesia pain management and does a lot of interventional procedures, as well as Kong Yu, who's helps us with chronic pain management. We're also fortunate to have Greg Rudolph. Greg's been with the Swedish for many years and more formally with Swedish Medical Group a couple of years ago. So Greg is with us downtown. He's pain management boarded, but also addiction boarded. So that's been really helpful for our team. And all of us help support not just our procedures, but we have functional restoration programs that include PT and OT and psychology. So even though today I'm going to talk about opioids, obviously we're pretty proud of the fact that we can hopefully provide really comprehensive care and figure out what each patient needs at Swedish. These are my disclosures. Our goals today is to really give you an update on the overdose epidemic. It's not a prescription or opioid overdose epidemic. It's really a drug overdose epidemic. We'll go over some of the kind of maybe key changes on our understanding of pharmacology, which may be important to understand issues around tapering and addiction. It's important, what we're going to talk about today, to remember that there are still the Washington pain rules that were approved by the legislature in 2018 and then went into effect in 2019. And then I'll talk about the CDC guideline. The CDC guideline came out in 2016, and then in November of last year was updated. And so I'll kind of go back and forth because, the lowest denominator of what we need to do clinically is still the Washington pain rules. And then the CDC guidelines are really more just evidence-based guidelines, which I'll talk about and really highlight the important changes in the updated guideline, which is really going to be critical because I think there was some misapplication of the guideline in 2016 that led to some unfortunate issues with patients, as well as I think frustration with some providers. So I built in two cases at the end, so we'll include an acute pain patient as well as a patient you may inherit. We know patients may move from different clinics or they move from different parts of the state, or a provider may be retiring and you may be taking over a patient that's already on opioids. So I thought those two cases would maybe help give two nice examples of what you need to do and what you need to document. So again, we'll go over the overdose epidemic. We'll talk about, again, more importantly, the 2022 CDC guideline, but it's important to first understand some of the key areas of confusion with 2016. Because I think that's what the 2022 guideline was done for, to help kind of relieve some of the confusion around guidelines that were misapplied. And then we'll talk about tapering, some of the issues with, I don't maybe describe them as pitfalls, but things you need to consider when you're tapering a patient to hopefully can ensure that the patient does well and you can have a successful taper. And so again, we have the Washington pain rules that were legislated in 2018 and then approved in 2019. If you remember, about 90% of the pain rules are the same, whether you're a nurse practitioner, a DO, or an MD. But remember, all the different medical commissions actually had a template. 90% of that was the same across the different groups. But then each group was able to make some minor changes with regards to CME requirements in a couple areas. Clinically, which unfortunately maybe led to some unnecessary confusion. So I'll try to include that as well. And then, like I said, we'll focus primarily on the 2022 guideline from the CDC. It's important to remember first, just the public health challenges around chronic pain. This is from the National Health Survey that looks at I think it surveys about 34,000 people a year. This is where the government gets most of its epidemiologic data for anything health related. But what they found, even back in 2015, I think this was 2015 to 2017 data, was that 50 million Americans have chronic pain. A new term that we're using is high impact chronic pain. That's 20 million Americans. That's pain that limits life work on most days during the past 6 months. I like to think of those high impact chronic pain patients are the patients that are probably likely to seek medical care. We know a lot of patients or people in society may have pain, but they may not receive any medical treatment. So that's probably that first number. So 20 million Americans is, 1 in 12 Americans with significant high impact chronic pain. And then we know opioid use disorder. This number is probably underreported. At last was 2 million Americans. We probably think that's higher. So it's, again, important, just the significant impact. And then if you take this and then throw in COVID and all the issues around what happened with the health emergencies, I think it led to some other problems as well. So most importantly, though, just as kind of a context, is to really think about pain, whether we're talking about opioid management or non-opioid management. It really needs a biopsychosocial model. And so if we look at two patients here, Jane and Tim, they both may have a pain of 8 out of 10, but to that person, their pain experience is very different. That can vary based on functional disability, depression, physical injury, genetics, environmental stressors. All of those things are going to impact how their body responds to pain and what they're feeling. And so below that, I have their morphine equivalent. Jane on the left may have 0 versus Tim may have 60. So morphine equivalent, I think, is maybe a marker for just when you're looking at opioid prescribing, but understanding that there's so much more to what's happening with the patient. And that's what you really need to be thinking about, especially when you're thinking about risk mitigation and trying to do the right thing and protect patients and monitor patients that may develop problems. So I think in our state, we've been fortunate. There was the AMDG guideline that came out a number of years ago, even before the CDC. If you think about the CDC guideline, it was primarily based on the work that was done here in the state of Washington. I think now we're on the 3rd rendition of the AMDG guideline. We also have the BRE collaborative. So Washington State really is pretty rich in kind of putting together evidence-based guidelines. And so a lot of what we're talking about, especially when we talk about the pain rules and CDC, is really based on that early work. And I think over time, as our understanding has changed, we've adapted those recommendations as well. After the 2016 CDC guideline, there was still this significant healthcare emergency looking at problems around opioid overdoses and drug overdoses. HHS put together an interagency task force, and they did a comprehensive report on what needs to be done with acute and chronic pain management. And the take-home message from this group was they put together really the importance of the pain management, whether it's acute or chronic, needs to have a biopsychosocial model. And they broke it down into 5 areas. Instead of step care, they talked about all 5 of these areas are important to consider from a treatment standpoint, and that would include medications, restorative therapies, which are things like physical therapy and occupational therapy and exercise, interventional procedures, spine injections, joint injections, behavioral health approaches, and then complementary and integrative health. And so the key is each patient you want to look at individually, and then from their needs and what their desires are, develop a plan based on those 5 areas. And then across all those 5 areas, you need to risk assess. You need to be considering stigma, what's their access to care, and the importance of education across all these 5. So I think this is a nice model to kind of look at with each patient what you're going to do. And then just looking at the overdose epidemic, and again, I don't want to underestimate the significant impact on patients, on family members. We have a huge drug overdose epidemic in this country. I was just driving in today to work, and there was another story about fentanyl and illicit fentanyl and what we can do to try to decrease that, what the government's trying to do. This data is up through 2021, I think, where we surpassed 100,000 drug overdose deaths. 78,000 were due to opioids. 69,000 of those were due to fentanyl or illicit fentanyl. If you can see in the different colors there, which I think is interesting, is in that pinkish color, cocaine deaths continue to increase. We have increases in, again, illicit fentanyl, which is pretty much 70 to 80% of the overdose deaths now. Even, counterfeit prescription opioids have fentanyl laced in it. So unfortunately, patients with substance abuse disorders don't even know what they're buying. And we're seeing this troubling increase in overdose deaths related to illicit fentanyl. The number of prescription opioid overdose deaths has stabilized. That doesn't mean we can't do more to try to limit patients developing problems with prescription opioid overdose. And it's also important to remember that most of these overdoses, unfortunately, include multiple medications. So this just gives you a kind of a sense of where the numbers are going. What I thought was more troubling was in the state of Washington in 2021, we surpassed 2,000 drug overdose deaths. In the past, the numbers were in the low 1,000s. Again, one death is unfortunate, obviously, for so many reasons. And just from, I think, 2019 to 2020, there was a 66% increase in overdose deaths. Most of that was related to fentanyl. And so you're seeing a lot from the government side in trying to, get in front of and limit illicit fentanyl overdoses. This is actually from the state. The ADAI is a great website that has really good up-to-date Washington numbers. And this just shows in red overdose deaths. This is deaths per 100,000, which is a common way to look at this epidemiologically. I think in the US, it's 34 per 100,000. We're at about 22 for opioid overdose deaths. In that greenish color is around 17 per 100,000, which is mostly related to illicit fentanyl. And then you see in green, commonly prescribed opioids or prescription opioids is actually kind of trending down since 2008. Still an issue, about 6 or 7 per 100,000 in the state. And then in purple is heroin. And we actually saw a slight drop in heroin overdose deaths, but again, still troubling. But the key is really illicit fentanyl, but also being cognizant of what happens with prescriptions. This was actually data from COVID, and they looked during the months from March of 2020 through March of 2022. If you look to the left, all drug overdoses went up by 43%. We know there's an increase in alcohol and all sorts of other substances and increases in depression and anxiety just in general. So it doesn't surprise me that we saw an increase in morbidity related to drugs. Heroin went up by 40%. Heroin went down actually for a short period of time, but natural or semi-synthetic opioids increased by 9%. If you look at synthetic opioids, almost an 80% increase. That's primarily illicit fentanyl. Cocaine went up by 45%. In psychostimulants, which many times gets missed or I think ignored, went up by 87%. And psychostimulants still remain a very big part of the pie, unfortunately, with drug overdoses, not in this just country, but in the state of Washington. From a prescription side, on the medical side, this is, I think, now the 12th consecutive year that there's been a decline in prescribing. We're seeing it in the pain clinic. There's a lot of patients that had been on higher doses that have been tapered down. Total opioid prescriptions have decreased by around 45%. MME has decreased by 55%, especially looking at the higher MME patients. That doesn't mean we don't have patients that are still on higher doses that we need to be careful with, as well as new patients that are on opioids that we're managing as well. There's been a huge increase in PMP queries. Before this was very small. It's probably up in the billions of queries that are done across the country now, which also helps, I think, to mitigate some of the risk with prescribing. And so I kind of just like to think of in the past, maybe there was so much of a focus on that this pain could be just managed with opioids. And we thought about non-pharmacologic therapy, but really weren't relying on it as much. And I think where we've moved is understanding that to the right, PT, OT, behavioral health, interventional procedures, complementary education, mind-body techniques, all of those can be used to help manage patients with pain. And maybe opioids are there for certain patients that may benefit. But looking at this kind of more holistically with these other types of treatments. Just for some references, this was a meta-analysis that came out in the last year and actually looked primarily at chronic low back pain, but showed if you look across multiple studies, there was very low to low certainty findings with short or intermediate term opioid therapy. So this is from, I think, 5 weeks to 15 weeks. They may cause a relevant reduction in pain, but there was also increase in adverse effects. And then for long-term opioid therapy, though the meta-analysis showed that chronic opioid therapy may not be superior to non-opioids in improving pain or disability or function. So really just cautioning you know, that the evidence is weak. It doesn't mean that there aren't patients that could benefit from this therapy. And unfortunately, it's what we see across the board with other pharmacologic managed techniques. Sometimes hard to really show evidence. And that's why it's going to be important to really do this on a patient by patient basis. And then just for some background with opioids, you know, there's different types of opioids. If we crack this opium poppy here, about 10 to 15% would be morphine or codeine. That's based on the opium poppy. We then have the synthetic phenylpiperidines, the synthetic pseudopiperidines. All of these have very wide ranges of analgesia. The naturally occurring alkaloids, morphine, codeine, and thebaine. Thebaine is actually what buprenorphine is derived from. And then we have the semi-synthetics. It's primarily what we prescribe, and then the synthetic opioids. What I think is most important is, you know, we're understanding a lot about the reward mechanism of opioids and the kind of overlap with addiction that can happen with these medications. But this was put together by Nora Volkow's group at NIDA. And I think what this does, it nicely explains really how opioid receptors work. If we think of opioids, there's mu, delta, and kappa. Okay, so this shows this kind of mood, euphoria, pleasure continuum of what opioids do. And so, although these all bind to the mu receptors or the opioid receptors, their ability to act at the second level varies. And so that's where we see a change. So if we look at the mu or MOR receptors, they actually have a strong connection with euphoria and stress coping. So that would be something patients would like. Versus on the opposite end with kappa, sorry about that. Click this. Or KOR, that's more dysphoric. It can cause negative affect. There's a thought that binding to kappa actually inhibits mu. So it may cause more dysphoria. So that would be low on that mood continuum. And then to the left is DOR or delta opioid receptor. That's more anxiolytic and may cause more positive affect. So I think if you remember anything from the talk today, this triangle, I think, helps to describe why each patient may report something different from opioids. And that's separate from craving or things like that. So we do have patients that have, you know, anxiolytic effects from opioids. Many patients, especially when you see this in the hospital, if you give them opioids, they get dysphoric or can't tolerate opioids. So I think this helps us to understand the complexities with these receptors. So again, the CDC guideline came out in 2016. It was really based on the recommendations that had been floating around for a number of years before that. I think it was good that it was all put in together into 12 recommendations. Unfortunately, though, the recommendations were somewhat misapplied, and that led to some problems that we'll talk about with regards to dosing thresholds. Some patients were unfortunately taken off their medicines abruptly, and we saw this kind of pushback because we saw harm that was done to some patients. So that actually the authors of the CDC came out in 2019, kind of strongly explaining that this is really guidance. It's not supposed to be legislative, and talked about some of the issues around how the guideline was being misapplied. And actually our own state Department of Health also set out certain specific letters in 2019. And a lot of that led to the CDC working behind the scenes to reevaluate the guideline. And then, like I said, in November of this year, the new guidelines were published. So if you look at the previous guideline, and this breaks down the 12 recommendations, it was broken into 3 parts: determining the need for opioids, opioid selection as the second part, and then the third part was assessing risk. I highlighted where some of the, I think, the confusion came around. If you look at the 4th bullet or 5th bullet, it says use caution at any dose, reassess benefits and risks when the dose reaches greater than 50 morphine equivalents, and avoid increasing a dose greater than 90 without carefully justifying the decision. Unfortunately, I think what happened here was a lot of pharmacy planning groups, even state legislatures, saw this as a cutoff of 50 and 90 morphine equivalents, and that led to a lot of confusion. The other one was the recommendation below that said long-term use begins with the treatment of acute pain. 3 days or less is often sufficient, and I think it mentioned 7 days at the most is usually is all that's needed. And so we saw a lot of legislation that was written in pharmacy policies around 7-day limits and 3-day limits for prescribing. And so that's important here because with the new guidelines, they've updated those important areas. So the lessons from the guidance were, again, the authors were very clear that the policies from 2016 that were developed from that were inconsistent and went beyond the original recommendations. And so it's going to take time for a lot of the state legislatures and even the pharmacy benefit plans that I think misapplied the guideline to really update them based on this newer guidance. But the misapplication included extending to populations not included. So the original guideline did not include cancer patients in palliative care. And we saw cancer patients, having dose limitations and things like that. The misapplication also included rapid opioid tapers and abrupt discontinuation without collaboration with patient. And if you think about that, what do you think would happen to potentially a patient? That really could put a patient at risk, right, for maybe using street drugs or self-medicating or destabilizing them, which can lead to other problems. The other misapplication included rigid application of thresholds. It was never mentioned that you had to be lower than 90 or lower than 50, but those were, in a sense, speed bumps. Duration of limits by insurers and pharmacies, and then sometimes we were seeing patient dismissal and abandonment, which is probably the worst thing you can do to destabilize a patient with chronic pain or a patient with substance use disorder. So the key was to greater specificity is provided in the new guidelines, and the idea of flexibility in weighing benefits and risks for each patient is really being highlighted in the new 2022 guidance. And they're very clear in the opening statements with the guideline that this is a clinical practice guideline. It's intended to improve communication between clinicians and patients, improve safety and effectiveness of pain treatment, and to mitigate pain, improve function and quality of life for patients with pain. Okay, so that's, again, they're trying to be very careful that they don't get a misapplication like what happened in 2016. So with the new updated guidance, they have changed it to include 3 groups. Before, it just included acute and chronic. If you remember, in the state of Washington, we did this before with the pain rules, that there's acute pain, which is less than 1 month, subacute pain, which is prescribing from 1 to 3 months, and then chronic is greater than 3 months. So we're familiar with this concept, but the CDC felt that subacute was important. We all can appreciate if you have a patient that's put on opioids, say for surgery, the 1 to 3 months after surgery is really critical to determine if they need to be on that medication or not. So a lot of emphasis was put on kind of clarifying and defining this subacute group. Even though from a clinical standpoint, 1 to 3 months is really a short period of time, and maybe 1 visit in your clinic when they're considered subacute. So the new guideline is not a replacement for clinical judgment. It's not intended to be applied as an inflexible standard. It's not a law, a regulation, and it is not applicable to sickle cell disease, cancer, pain, or palliative care. And it's not focused on opioids for opioid use disorder. There was some pushback from pharmacy benefit plans using the CDC guideline to limit our prescribing of buprenorphine for opioid use disorder as well. So it's important to remember what the new guideline is not, because I think that's where physicians and nurse practitioners and prescribers sometimes feel frustrated. So it's also important to remember, even after the 2016 guideline, tapering guidance came out from HHS, which I think this is a really good and easy to read document. And I have that reference there for you. The key with tapering first is what we've learned from, even before 2016. If you're going to taper a patient too quickly, that can lead to sometimes harm. This was a Kaiser study that looked at the risk factors. Early on, the thought was that it was really dependent on dose. And what they found was it was really dose fluctuation was associated with the highest risk of overdose. So that period when you're tapering a patient actually put them at the highest risk. On the end range, it was associated with high doses. But the key here was that the fluctuation in dose is what destabilized patients and increased their risk significantly for overdose. And here was a dose variability of around 2730 MED in a short period of time was increasing their risk. Another study, this is from a Harvard Review study in primary care, where this was in a safety net clinic. Most of those patients, if they had an abnormal urine screen, were discontinued from opioid therapy. It was before really the initiation of buprenorphine in some of these clinics. And what they did was they tracked those patients that were discharged from the practice over the next year, and they found a significant increase in overdoses and deaths in that group. So the key was destabilizing those patients was actually the highest risk factor for overdose and death. So again, they felt it led to a disruption of the continuity of care of the patient. And so again, really highlighting the importance of safety with tapering. And these are just other studies. This came out in the last year. This was from an Oregon study, I think data through 2017, where they looked at different types of opioid reductions, patients that were abruptly stopped, patients that were slowly tapered. And what they found was the risk for suicide increased in those patients that were on high doses that were abruptly discontinued or had a rapid reduction in their dose. So again, highlighting the importance of caution that's needed when you're tapering a patient, especially high-risk patients. And then the second study was just a meta-analysis that looked at with deep prescribing, and deep prescribing is where you're taking a medication and slowly decreasing it for a patient. That a lot of these are based on small number of randomized trials. They mostly include high-risk patients, not low-risk patients, and so just wording some caution about how we look at some of the tapering studies. So I've seen a lot of patients slowly taper, which I think can be really good, but it takes time. It takes a lot of buy-in from the patient and the prescriber as kind of a mutual goal-oriented approach, which we'll go through. So this is from HHS and when to taper patients, and that's only after a thorough assessment of the risk-benefit ratio. Consider patient-centered, again, compassionate tapering. Assessment should be concluded in a collaboration with the patient. They shouldn't be tapered rapidly or discontinued suddenly. I have patients that we taper. It may take us a year to slowly taper their medications down, or we'll taper for 2 or 3 months, 1 or 2 pills a month, and then hold the taper. And so again, this is really a long-term relationship that you need to have with your patient. And you really should never feel rushed to do this. And at the same time, remember that you need to be adding other types of treatment and trying to figure out, how can I do a better job to help them manage their pain as at the same time, considering tapering. And this is from the pain rules in the state of Washington. Consider tapering when the patient requests it, when they experience a deterioration in function. There are other treatment modalities may be indicated. There's evidence of misuse, abuse, or substance use disorder. They've experienced severe adverse events or even had an overdose. These are just kind of like some nice guidance on when to consider tapering for patients. And this is based on the Washington State pain rules. The key is, when doing this, and even our pain rules talked about that you need to do a risk assessment for all of your subacute and chronic patients. And I think for that matter, even patients with acute pain, thinking about what are their risk factors for prolonged use or other, problems with regards to taking opioids. So you really need to use a biopsychosocial approach, doing a good physical exam. I see many times patients come in and they've had the same diagnosis for 10 years, but they really never have had a physical exam again or another workup to consider what else is going on with their pain problem. When you risk assess patients, can you break it down into low risk, medium risk, or high risk? And we have tools at Swedish that we've developed that help to risk stratify patients. The low risk patients, maybe you wouldn't need to do as many urine screens versus the high risk patient. You have a tighter screening with those patients, seeing those patients more often, doing more urine screens and things like that. And again, remember in the state of Washington, if they're subacute or chronic, they should have some type of risk assessment done and noted in the chart. So again, I know we are limited on time, but there's obviously different ways patients can present, where they acute pain patient, high dose patient, a post-surgical patient with subacute pain, a patient getting rewarding or anxiolytic effects from opioids. Maybe they don't get great pain relief, but it's the only thing that helps relax them 2 or 3 times a day, and they're dependent on that. And then you have the patient that's maybe diverting. They've got a pain diagnosis and they're selling their medication. So the patients can present differently, and I think that's a challenge for us as clinicians in what we can do. So these are the recommendations, the new recommendations. Most of it's the same. The first recommendation still says that non-pharmacologic therapies are at least as effective as opioids for many types of acute pain. So it's a little different from before. It actually kind of elevating the recommendations for non-pharmacologic treatment for acute pain, and the importance of maximizing the use of non-pharmacologic and non-opioid therapies. And if you're going to use opioids, they should be part of a broader treatment program. The third is when starting opioid therapy for acute, subacute, or chronic, you should prescribe immediate release, not long acting. So that's similar to before. Using a long acting opioid in an opioid naive patient increases their risk because there's a lot more opioid in the system. The fourth recommendations, this is where it's important. The previous 2016 guideline didn't do a good job of distinguishing acute prescribing versus what to do with patients that are chronic opioid patients. And so in the new recommendations, they clearly differentiate those two groups. In number 4 states, when opioids are initiated for opioid naive patients for acute, subacute, or chronic pain, prescribe at the lowest effective dose. If opioids are used for those, use caution with any dose. And they've removed the 50 and 90 morphine equivalent thresholds. They're not saying that it's okay to keep increasing opioid dose, but they remove those because there was so much confusion. So you really want to be careful and make this individualized, even with those opioid naive patients. And then the fifth recommendation is the one that's specific for patients already on opioids. So you want to carefully weigh the benefits and risks. If benefits do not outweigh the risks, optimize other therapies and work closely to gradually taper to lower dosages if warranted. If they're doing well, their function stable, you don't have to decrease their dose. And so again, I think what's most important kind of take-home message is there's now specific recommendations for what to do with opioid naive patients, and then what to do if you already have a patient on chronic opioid therapy. And that's what we saw before some of the misapplication. Patients were on higher doses of opioids for many years, and then they would also quickly be just reduced to less than 90 because people thought that was going to be safer for them. But again, the good thing is most of our patients are actually on lower doses now. So I think we really have to be looking at these other areas as well when we're looking at trying to limit any harm for patients. Because again, most of our patients are on probably less than 50 morphine equivalents now. So this is our patient. This is a 76-year-old with acute right knee pain. She had a non-displaced tibial plateau fracture 10 days ago. She's got obesity. She had a recent GI bleed. She saw orthopedic surgery. They did not want to do surgery. They wanted to treat her conservatively. She can't tolerate NSAIDs. The daughter's worried that mom's going to have to move in with the family. She's having trouble from a functional standpoint in taking care of herself. So it's Swedish, and again, I was talking to Mark before the presentation. You probably have dot phrases. This is a dot phrase we use that kind of helps organize our notes for our primary care providers. We have pain plan acute, pain plan subacute, and chronic, and it helps kind of walk them through the pain rules and kind of the evidence-based approach to what you should be doing. For acute pain, remember in the state of Washington, there's prescribing limits. It's not prescribing limits by itself, it's prescribing limits without documentation. So if you don't document, the first opioid script for acute pain is supposed to be limited to 7 days, 14 days for perioperative pain, and then 14 days for subacute pain. So that's why you see a lot from the pharmacy benefit plans of like limitations of 42 pills. They base that on 6 pills per day for 7 days or 42. But again, even if you look at the pain rules, there were prescribing limits, but that was only without documentation. So say you do have a patient that needs more than 7 days with the first script, I write a note at the bottom of the script, patient, why I'm doing more than 7 days. But again, it's really without documentation. There's not a real true prescribing limit in itself. And so for this patient, we have pain phase, pain function, medications, and the prescriber can just click through these, and this way it'll kind of organize their note and make sure they cover all those important areas. Is this acute? Is it subacute prescribing? Is their function stable? Is it worsening? Is their pain changing? Or is it getting better? And then, if function's improving, what their current medication plan is. Again, just kind of a nice, I think, way to organize your note and make sure you're documenting those important areas with your patient. This is the PDMP, and in the pain rules, if you remember back before, they had different rules about when you need to check the PMP. But since most places have a fully integrated PMP in their electronic medical record, if that's the case, prescribers need to check the PMP for any controlled substance. So stimulants, anything that will be controlled, Schedule 2 through 5, you need to be checking the PMP. So we can check our PMP. In the last year, the group actually that the state had their contract with changed, so the reports look a little different. But I have a dot phrase that automatically links in timestamps that I check the PMP. You know, you can see in the PMP any controlled substances they have, who the prescribers are, and then, you know, what medications they're on and what date it was prescribed. So I pre-chart, I have all this information in my note. And then when I see the patient, I can easily tell when their refills are due, and you can pick up on other meds that they may not even be aware of, or that they don't realize are controlled substances that they're getting. And then we have this built into our note that we've checked the PMP, expected refill history, no pertinent concerns, or there's a possible duplication of refills and things like that. So again, this is just an easy way to keep our prescribers and our physicians and their nurse practitioners to keep their notes in order and make sure they're covering all these different areas. And then again, it's important to remember the pain rules talked about the importance of looking at pain, enjoyment in life, and general activity. And the pain rules recommended PEG. The CDC guideline also recommended using PEG because it can cover not just pain, but again, psychosocial function and physical function. So we use PEG across the board as our pain assessment tool. And then this is when deciding the duration. So this is recommendation 6. When opioids are needed for acute pain, you should prescribe no greater than the quantity needed for the expected duration of pain. They removed the 3-day and the 7-day limit. But again, you still want to be careful. Most of our prescribers and patients that leave the hospital have less than a 3 or 4 day supply, which is great. If you think about in the past, patients were, you know, discharged with a first-time prescription with, you know, 30 pills, and they probably used 1 or 2, and then 28 went into their medicine cabinet. And then who knows what happened to those medications. So still an emphasis on not over-prescribing for acute pain, but they removed any mention of dose limits. And then reevaluate benefits and risk within 1 to 4 weeks. So we get patients back or have a virtual visit. You know, you want to closely monitor these patients, especially early on when you're deciding, and hopefully that's going to help limit any prolonged use of opioids that are unnecessary. So for the last couple of minutes, I'm going to go over our second patient. This is Thomas. He's a 64-year-old with low back pain. He moved here from California. He had a laminectomy. He's moved here to be close to his family. He was able to get his medical record sent, and in Care Everywhere, our shared medical record, we were able to see his notes. So we were kind of lucky that we were able to see all the notes from his previous prescribers. He has a history of COPD, depression, and insomnia. These are his medications. He takes 5 milligrams, 325 of oxycodone acetaminophen 4 times a day, so about 30 MEDs. He's on gabapentin. He's on a low dose of alprazolam, though, for many years for sleep, he thinks, and he's on sertraline for depression. We checked the PDMP, and he did have a prescription filled when he moved, and we're able to see that in the Washington report. We did a urine point of care testing, and I'll go over that in a second. On his physical exam, he had trigger points in his gluteus muscles. He had chronic nerve root irritation and an L5S1 distribution. So we found some things on physical exam that we could potentially work on. If we think of this patient, so now you've inherited a patient already on opioids. If you look at the pain rules, and the pain rules from the state of Washington from 2019 specifically said when you get a new patient on opioids, you have 90 days to do nothing. And the key is you really want to use the first 3 months to get to know the patient, work up the patient, get familiar with the patient before you even have to consider, do they need a consult? Do they need to be tapered? And I think this was smartly done to really assure primary care providers and any provider that gets a new patient on chronic opioids to really establish a good relationship with the patient before even considering doing anything different. And so again, that's something just to mention. It's in the pain rules, and I think it gives our primary care doctors some good time to get to know these patients before you may even consider, do they need to be tapered or do they need the consult? So going back to urine monitoring, and I'll talk about risk stratifying and naloxone considerations. I try to put all this together into this last case, and then what to tell patients to do about safe disposal of unused medicines. These are all things that I think you can apply to any patient you're seeing, whether they're acute to chronic. So I wanted to include this here for the last couple of minutes in the presentation. So with urine drug screens, it's important to remember that the point of care testing is an immunoassay. Immunoassays are antibody-based tests, and they're based on the opium poppy. So that would be morphine or codeine. So the immunoassays in urine screens that we're familiar with for many years have always been good at picking up morphine and codeine, but do a horrible job of picking up synthetic opioids. Now, over time, the point of care tests have gotten a little bit better where they can pick up some of the synthetic opioids like oxycodone and hydrocodone. But most of these patients, you really need to send for confirmatory testing. So confirmatory testing is usually done by gas chromatography. It's at high sensitivity and high specificity. The confirmatory testing will break down the metabolites, and then you'll be actually able to confirm if the actually point of care testing was correct, and that'll give you a lot more clinical information. So it's really rare that you would base any clinical decision making just on the screen, because the immunoassay screens have a really low sensitivity and specificity. You can have false negatives and false positives. The immunoassays are rapid, so you can get some kind of a sense in your clinic, but you need to be familiar with the limitations of whichever screening tool you're using, immunoassays tool, but then send for confirmation to really kind of clarify before you make a decision. And so if you're going to do urine screening, I think you've seen this before, you really need to know metabolites. So codeine, for example, is broken down to morphine. Hydrocodone is broken down to hydromorphone. So when I get confirmatory testing for any hydrocodone patients, I see hydromorphone in almost every patient. It's really rare not to see hydromorphone as a metabolite of hydrocodone. Now, if they're on hydromorphone, it's not going to go backwards. You're not going to see hydrocodone. Oxycodone is broken down to oxymorphone. Oxymorphone is an opioid that's available still, but it's important to remember that oxycodone is broken down to oxymorphone. And if a patient, unfortunately, would be using heroin, you can get 6-man, which is usually within 25 to 30 minutes, and then they may be pan positive for morphine and everything else. And this gives specific gravities, temperatures that patients are supposed to have for urine. You want to make sure patients aren't adulterating their urine sample or anything like that. So that's just kind of a quick overview of the metabolites for urine screens. This was a review we put together a number of years ago. It was a white paper on urine monitoring, and it has a nice overview of some of the false positives of other drugs causing positive screens. So amphetamines, benzos, cocaine, you can get positives for that with these different medications. I've seen sertraline trigger a positive benzodiazepine in a patient. So be familiar with this. Also, even if it's a couple times a year, call the lab that's doing your urine testing if you have questions. They will know which drugs have high false positive rates and can help you as well. I've had patients on quinine that have tested positive for opioids. So I've seen this before, and it just makes you appreciate doing the confirmatory testing. It's really going to help you to distinguish if it's a false positive or a false negative. So this is a good, the white paper actually does a really good job of explaining urine screens and confirmation testing. So finishing up here, this is the last part of the recommendations. Before starting and periodically during opioid therapy, you want to incorporate strategies to mitigate risks, including in offering naloxone. And so they don't specifically say who needs to get naloxone. If you saw in the media a couple of days ago, the FDA advisory board actually approved the development of OTC naloxone. So we may be seeing that in a number of months coming out. But now you need to do it by prescription. But it's really easy. Most pharmacies you can get naloxone without even writing the prescription. There's an open script that the healthcare authority that did a couple of years ago. Naloxone is going to be important for, I think, any patient that has kids in the family, in the house, and actually more of even having like a fire hydrant or a fire extinguisher in their house. You know, it's if you can't predict not just the patient, but someone else having an opioid overdose. And naloxone can obviously, as an antagonist, quickly reverse respiratory depression and save lives. So naloxone is going to be important. We'll talk about that in a second. But they don't give specific doses of when you should do it. We prescribe naloxone to patients that are at any type of risk. And even my patients that are just on chronic opioid therapy, I offer them naloxone to have it in their home just in case. And then recommendation number 9, when prescribing initial opioid therapy, you want to review the PMP data. Again, if you have an integrated PMP in your electronic medical record based on our state, you're supposed to check with any patient anyway. So I think it's even more straightforward now about the importance of the PMP. And then toxicology testing, they don't give specific recommendations on when you should do testing. but they say when prescribing for subacute or chronic pain, consider the risk of toxicology testing. And I'll show you how we've considered it in ours and what the pain rules state. The pain rules state if it's a low risk patient, at least once a year. If they're medium risk, twice a year. And if they're high risk, you should consider it quarterly, based on your clinical findings. And so this is just some dot phrases we have that walks you through the informed consent. Do they have naloxone at home? We have an opioid management classification system that we put together that kind of walks you through a 3-step process to classify a patient if they're low, medium, or high risk. And based on that is how we determine how often we're going to do urine screening and how often we may want to see the patients in clinic. And this way we can kind of just assess patients individually. And then going back to the co-prescribing rules, even in the state of Washington, there's this important risk with opioids and benzodiazepines, increase in the risk for overdose. So the pain rules in 2019 said that you shall not prescribe with opioids these medications without consultation and without discussion of risks and benefits. It doesn't say you can't do it, but you need to document why, and you should really try to avoid it. So it's not just benzodiazepines, but barbiturates, sedatives, soma or carisoprodol, and even the non-benzodiazepine hypnotics or Z drugs like Ambien may increase the risk for drug-drug interactions and respiratory depression. And confirming, this is again with naloxone prescribing from the state of Washington. They say if you're an MD, if they're high risk, they don't define what high risk really means, but it's more for high risk for developing addiction, you should prescribe naloxone. If you're a DO, the rule is if it's over 90 morphine equivalents, you should recommend naloxone. And then if you're a nurse practitioner, it's technically if they're any patient on greater than 50 morphine equivalent, which is many patients, you should offer naloxone. We've made it easy. We pretty much offer naloxone to any patient, but those patients that are higher risk, I'm really making sure that those patients have naloxone in the home. The families know what to do in case the patient is sick and has respiratory problems, and then unfortunately gets toxic and develops respiratory depression. So again, I think you need to look at it individually, but I wanted to remind us of what the pain rules state with regards to prescribing naloxone. And they talk about using tools. We use the opioid risk tool. The opioid risk tool is a tool to help you identify a risk for aberrant behaviors. It's not for addiction, but it looks at family history of substance abuse, personal history of substance abuse, age, history of pre-adolescent sexual abuse, and psychologic disease. And so our feeling is if any of those things are not treated, like depression or anxiety, they get points for that. 0 to 3 points is low risk, 4 to 7 is moderate, and greater than 8 is high. I think this is just really a good social history. Many times we don't take the time to do a good social history. The family history of substance abuse, personal history of substance abuse, all those things are going to be important for you to know because those things are going to increase their risk potentially. So we use the ORT as part of our risk assessment. So in our pathway, we developed this opioid pathway a couple of years ago where we look at not just their morphine equivalent, but their opioid risk tool. So we have 2 adjustments. The first is looking at is their opioid risk tool score higher than the morphine equivalent? If it is, they maintain that score. And then they can adjust up or down based on the second adjustment. The second adjustment looks at medical comorbidities and other, the second part being concurrent use of other medications that could put you at risk. So this forces the provider to go through and really think of those other medical issues and medicines that are going to increase their risk. And so if they have those, you can you can increase their score. If they don't have any of those, you can adjust their score down. Okay. And so if they have 0 points and they start at high risk, you could decrease their risk stratification to moderate or medium. And so this, again, really forces the clinician just to take a couple seconds to think about those other medical comorbidities and then adjust more specifically based on that. So here's an example. This is patient's 30 morphine equivalents, low depression and anxiety. We have a tool in Epic that walks us through his opioid risk score was low. He's on medium dose. His MED is low, 30. So he has a tentative adjustment of a low risk. But then when we look at the second adjustment, he's got COPD, which is poorly treated at times. He's on benzodiazepines, so there he scores 2 total points. So since he has those 2 points, we actually scored up. So he went from low to moderate for his risk stratification. So then we put that in our chart, management classification moderate, based on COPD and benzodiazepine use. And then each year we reassess their risk assessment stratification. So naloxone, I mentioned that. Again, we may see it going over the counter in a number of months. But again, you can prescribe it easily. Most pharmacy benefit plans have to cover naloxone. And so I bring that up with patients and I document that in my chart. And most of the times the pharmacist can do the education around how to use naloxone. I may give patients information about naloxone from the medication guide on one visit. I tell them to read that. When they come back, we'll go over it and then prescribe the medicine. So sometimes it may take a couple visits, educating them about naloxone use. And then I think you'll get more buy-in with the patient that's going to actually pick up the medicine and have it at home. And then following up over time, do they still have the naloxone? Do they know where the naloxone is? And so we recheck that at least once a year. And there's different types. The common one is intranasal Narcan, 4 milligrams. Cloxato came out with an 8 milligram dose last year. Most of what's used is the intranasal 4 milligrams. These are the recommendations again about opioid pain medication and benzodiazepines. So they said that you should use caution. It doesn't say you can't do it, but you really want to be careful. A lot of those patients maybe don't need to be on chronic benzodiazepines. So what is the plan to help decrease that? Using other techniques, maybe for their sleep hygiene, other medicines to help them sleep, and while you taper them off their benzo. Or if they're on benzodiazepines, understanding that and communicating with their psychiatrist or whoever else may have them on that benzodiazepine for other reasons. And so I know we're getting close on time here. This is Thomas's case. So he's because it's our first visit with him, we decided we're going to give him a 2-week supply because we did our urine screen. He was negative for oxycodone, but we wanted to send it to get confirmation testing. But I felt that he was taking his medication, so I didn't want to cut him off. We referred him to pain psychology for cognitive behavioral therapy for insomnia. We started him on trazodone. We discussed that we were going to maybe have him see our physical therapist for spine stabilization. Again, we sent his urine confirmation and I documented that in the chart. He had naloxone script, but wasn't sure where it was since he moved here from California. So we sent another naloxone script for him. And then the plan for him was to come back in 2 weeks. And then we also, at that time, this is, a hypothetical case, the primary care doctor could maybe consider referral to the pain clinic if they had questions about his care and other things that he could potentially benefit from. So this is just kind of like that first visit, what you could do for the patient. You don't need to be rushed. You want to be careful. You want to develop a good relationship with that patient, and then kind of start the relationship and go from there. And this is about safe disposal of medicines. There's now take-back programs. You should be giving patients information about that. Takebackyourmeds.org. If they enter that, you can put your zip code in, and most pharmacies now have take-back boxes that are in the pharmacy for any controlled substance. And so they really recommend telling patients to return those medicines. If they can't get it to a take-back box, the FDA does still recommend flushing down the toilet, or you can put the meds in coffee grounds or kitty litter in plastic bags and throw it in the trash. And so those are the recommendations around, really trying to limit all these unused medicines that in the past were kind of floating around society. Okay. So again, I wanted to have time for a couple of questions here. Hopefully this is a kind of a quick overview for the pain rules and understanding some of the new guideline changes in the CDC that came out last year. Remember, these are not a replacement of your clinical judgment. They're not laws. They're just clinical guidance. So you really want to be documenting why you're doing things and what your short-term and long-term goals are with patients. I think that's going to be key. And remember, this is a biopsychosocial approach for any of your patients. So be thinking of the biologic and, the psychologic aspects that your patient's struggling with, for any patient with chronic pain, especially those patients that are on opioids. Okay, so we have time for a question. So I'm sorry, I kind of went close to 8 o'clock here.
Anybody have any questions?
Yes, this is Dr. Duffy. Can you hear me?
Oh, yes, I can.
Okay, wonderful. So I practice hospital medicine, and most of the time we prescribe very little acute pain opioids when we discharge patients. But recently I came across the article, I cannot remember where, that in summary that it was generalizing that opioid prescription is decreasing, but gabapentin prescription is increasing. And it was presented in a negative way because FDA does not allow prescribed for acute pain. What's your take on prescribing gabapentin for hospitalized and acute pain patients?
Well, yeah, so it's a tough question. I mean, gabapentin is a calcium modulator, and obviously it's 95, 99% of the prescriptions are off label. It's only the FDA approval is still for postherpetic neuralgia, but I think it was used because the understanding was even for acute pain that if you decrease calcium influx, that could decrease maybe opioid requirement and potentially help with pain. So I still think it can be used off label. There was an increase in some of the abuse data across the country, mostly in prisons where gabapentin was being abused. But a lot of the antidepressants and a lot of other meds are also abused. So I think there was a big emphasis of really looking at gabapentin. I still think gabapentin can be used to help patients. A lot of times it's actually, they're underdosed. I mean, the doses for pain are 1,000 to 3,000 milligrams. So many times we see reduced doses. On the other side, though, I do think I saw patients that maybe were on opioids and I said, well, the prescriber's like, well, I don't prescribe opioids, but let's try gabapentin. And I don't think, day to day using gabapentin for acute pain is really that good unless it's, again, postherpetic neuralgia or severe neuropathic pain. So I think it's kind of all over the place. If you are going to use it, one is the dose appropriate. And again, the dose is usually 1,000 milligrams when you may get analgesia. And then, 3,000 milligrams is the recommended dose for pain. So for going back to your question, I think in the hospital, there may be efficacy, but you do want to get them on high doses. I have patients that come in on these really low doses, and I'm not sure if it's really doing anything. So that would be probably the first thing. And the other second point is that there's some talk that there's an increased risk or that there's been abuse of gabapentin. Again, I think it's small. There's very low to minimal risk of any kind of addiction. I don't think I've seen a report of addiction to gabapentin. And also remember, at high doses, the gabapentinoids, like other anticonvulsants, can be mood stabilizers. And so they can have anxiolytic effects at high doses. That's all off-label use. So I hope that helps you. It's complex. If you are going to use gabapentin, know the doses, because I think what happens is people are just getting put on gabapentin because maybe the prescriber doesn't want to use opioid medications and they think that that's going to be safer, but maybe it's not even helping the pain. So I hope that helps. It's a good question, though.
Thank you.
Dr. Stanos?
And I think Wilson Chang is with me. He's one of our pain physicians. I can't see the chat here, but I asked Wilson to join us as well. I don't know if Wilson's here, but yeah, is there another question? Oh, yeah, Wilson.
I'm here. Yep.
Yeah, question from Bill Kintner.
Yep.
Should we be trying to convert people who we think are going to be on opioids long term to buprenorphine? And if so, could you comment on the transition?
That's a great question. I mean, just yesterday, if you look it up, the VA, who actually wrote really good opioid guidance even before the CDC, the VA and Department of Defense had to really respond to the drug overdose epidemic many years ago. They actually came out with guidance saying that we should use buprenorphine for chronic pain even before mu agonists. And so that just came out a couple of days ago. Some interesting articles. Their review came out in it's their updated opioid guidance in the Annals of Internal Medicine. It just came out a couple of days ago. So I think buprenorphine has a lot of benefits. It's a partial agonist, but it does have analgesic effects. And so there are products like Butrans. There's buccal transmucosal buprenorphine that's actually FDA approved for chronic pain. So we've been using that even on our opioid naive patients or patients on very low doses of mu agonists that aren't doing well in converting them over. On the other side, sublingual buprenorphine is approved for opioid use disorder, but even the CDC guideline, the updated guideline, talked about that it should be considered with tapering. I think before, a lot of the pharmacy benefits plans wanted to say, well, it's only approved for opioid use disorder. But now there's actually more support from the government that even when you're tapering patients, that buprenorphine should be covered. So I think it's evolving. Going back to your question, I think where I see the underutilization is prescribers don't use the Butrans patches, which is actually indicated for more opioid naive patients or patients on low doses. But if they can start doing that, I think they'll get more comfortable with buprenorphine, separate from doing a taper from a high dose patient that gets converted to buprenorphine, on the other end. So yeah, it's interesting you brought that question up. I think buprenorphine has less effects on the central nervous system. There's obviously a respiratory depression kind of ceiling, so there's definitely safety built into it. That being said, we've had patients do great on buprenorphine. It's been life-changing. But then I have some patients that buprenorphine just doesn't help too. So I don't want the pendulum to swing too far that everyone thinks that everyone should just be on buprenorphine, because we have some patients that we've done tapers and they just don't do better on it. But on the other side, it's been a life changer. They've changed the guidelines with regards to the waiver and not needing the waiver anymore to convert patients. So, I think there's good movement to increase access to buprenorphine. So I'm glad you brought that up. But if you look at the guideline from the VA, it'll be easy to download it from the internet. They actually have some good guidance, and I think buprenorphine is a good option. Wilson, do you want to comment on buprenorphine?
Yeah, so I use it quite a bit on my daily practice for treating chronic pain. So like Steve said, generally bup came on the market for treatment of dependence. But in low doses, it's actually a very, very good analgesic. And just a quick note, typical Suboxone or Subutex that's used for methadone addiction or dependence is much, much higher dose in milligrams. But when it's used as a analgesic indicated for FDA labels for pain treatment, it's in micrograms. So it's if that gives you a little safety net as a provider or a prescriber, that's certainly a plus. And if you actually go to the Butrans website, which is the transdermal patch form of buprenorphine, there's actually a nice conversion calculator if you're ever wondering what how many hydrocodones equal to how many micrograms of buprenorphine. It's actually a very good gauge and tool to sort of understand the nature of the medication.
Yeah, like Wilson's saying, for the Butrans patch, I think, which is easy, like if you're opioid naive, you can start with the 5 microgram per hour patch. If you're on more than 30 morphine equivalents, you can start at 10. But I think most of those patients, you still want to get them on probably the minimal amount of opioids before you start Butrans, because like Wilson said, the patch is micrograms per hour, and so it's a very low dose in the system. So you really hopefully want to have them on the patch. We have patients maybe taking a little bit of tramadol or hydrocodone for breakthrough pain if they need it. But I've had a couple patients that they like the patch. They change it every 7 days and they don't use any short acting. And I think it's cleaner, like Wilson alluded to too. But again, it's a lot lower serum levels than even transmucosal, and then buccal is even higher serum levels like Subutex and Suboxone.
Thanks. That's very helpful. And for the transition, do you use, for instance, that Butrans conversion calculator and just switch them straight over, or do you taper down on one and up on the other? Or
I could comment on that. Yeah, so what you're referring to is a cross titration, and there's really an art to it. There's very little science, in my opinion, about it. Again, if you go to the Butrans website, there are certain recommended doses for the patches based on what they're premorbidly taking for hydrocodone, or based on the total MEDs. However, what you want to consider is 2 things. One is that if you use or transition them to a sublingual or a buccal regimen, it usually hits them pretty fast. So the onset of the kicking in of the buprenorphine is a little too sudden. And then what happens is if they have the pre-existing hydrocodone or whatnot in their system, it could actually cause precipitated withdrawal. So if it might really turn, it may not be as harmful to the patient from a medical standpoint. From a psychological standpoint, it really turns them off. They really don't like the medication if you kind of don't bridge them right. So a lot of our colleagues over at Ballard Addiction or Ballard Bridge Center, what they typically do is the transdermal patch is a much slower acting and a nice gentler transition. So they typically load them on with the transdermal patch. And once they sort of get a certain level in their serum levels as far as the buprenorphine goes, then they might transition over to a sublingual or a buccal.
Yeah, versus
formulation.
versus the more traditional method of having them have all their mu agonists out of their system, where you actually precipitate withdrawal and then start the buprenorphine. The one thing I'll say, and I still see confusion from pharmacists, and I don't know if Wilson sees this, the old thinking was that if you were on buprenorphine, you couldn't take any other opioid, that it would block the opioids. That's not true. And so we're seeing patients that are on a Butrans patch, for example, and they're given a little hydrocodone, and the pharmacist is like, oh no, that's contraindicated. That's not accurate. That was kind of old thinking. Not all of your opioid receptors get bind to buprenorphine. So that's probably the thing that needs to be worked out, because there's still some confusion out there. So, and then Greg Rudolph is happy to answer questions about that. Greg has probably thousands of patients on buprenorphine, and Wilson, like all our other colleagues, are actually prescribing more as well. And there is an art, like Wilson said, to this, and especially when you're tapering, because remember, buprenorphine can stay in their system for a long time. You have to go down very slowly, especially sublingual. It's not like the traditional mu agonists.
Thank you.
Thank you so much, Dr. Stanos, and thanks for joining, Dr. Chang. Nice to meet you.
Nice to meet you guys.
I'm going to go ahead and stop the recording. I know Dr. Stanos did have his email up here if you guys have further questions or want to reach out, but I appreciate everyone's time today.
Hard questions go to Wilson Chang. You can find him too. So.
Oh, yeah.
Well,
Yeah, and if
you
you have
guys.
questions